Hope Cook with Dermast.live. I'm excited today to have Dr. Matthew Zirwas. Dr. Zirwas has lectured all over the country. He's done, I was about to say millions of clinical trials. And he is nationally recognized as an Okay, I'm just making it up.
Perfect, that's what I do all the time.
Hope Cook with Dermast.live. I'm excited today to have Dr. Matthew Zirwas. Dr. Zirwas lives in Ohio. He's a dermatologist who has lectured all over the country. He's an expert in atopic dermatitis, contact dermatitis, and he does clinical research in all sorts of trials.
Exactly. I've done close to 100 clinical trials now.
Perfect. All right, so you gave a lecture today in San Diego at the SDPA conference on JAK inhibitors.
Yes.
Is there anybody you wouldn't put on a JAK inhibitor?
Ooh, is there anybody I wouldn't put on a JAK inhibitor? Somebody who was really scared, right? So I'm not going to try and talk a patient into it. But from a medical perspective, is there anything that I would look at as a contraindication? If somebody had known immunosuppression or very recent history of malignancy, that would be about it. So immunologic would be the only reason. I don't even think about, if somebody's got a high BMI, if they're a smoker, if they have high cholesterol, diabetes, hypertension. I don't ask, it doesn't go into my thought process because we just have so much data that the JAK inhibitors we use in derm do not increase cardiovascular risk. And so immunologic reasons would be the only reason that I wouldn't put somebody on a JAK inhibitor.
Okay. And if somebody has an active cancer, would you consider it with buy-in by the oncologist?
I would. So, and I don't think I have anybody who's like in the midst of having cancer, but I think I have at least one patient. Yeah, I can actually think of her. I've got one woman who had breast cancer twice and was about 8 months out from being in remission. Have her on JAK. Now I talked to the oncologist and we had tried everything else that we could think of, but I do have somebody and she's now been on the JAK for 2-3 years.
Okay.
Yeah.
And females of childbearing age?
Don't care at all. So no more than I care about spironolactone or doxycycline. So JAK inhibitors are super short half-life drugs. And so as long as I'm confident that they're going to know if they're pregnant and stop the drug, I don't think of it as any different than doxycycline or spironolactone.
Okay. What about ongoing labs?
Ongoing labs, so I do baseline and then 12 weeks. I really don't, I'd like to say that I do labs every year. Most of them I don't.
Okay.
So if they're a 50-year-old, I'm likely to be like, hey, you see your primary care doc regularly, right?
Yeah.
If they're younger than that, just when you look at the data with JAK inhibitors, there's about 1% of people who will get a meaningful drop in their hemoglobin or hematocrit or their platelets. Other than that, you just don't see and that always happens in the first 12 weeks. You just don't see meaningful laboratory abnormalities with JAKs.
So you do them at baseline, 12 weeks?
12 weeks, and then not really on any particular schedule after that.
Okay. Talk to me about CPK.
CPK has been such an interesting issue because we've had really no understanding of it. And one of the cool parts about doing clinical trials is that I've got hundreds of patients that I've monitored monthly labs on for years. And whether we're talking they're on a biologic or a JAK inhibitor or a topical. And first, you just see a lot of CPK elevations, period, whenever you do a lot of labs. It can be like, oh yeah, we had a harder than usual gym class, or oh yeah, I mowed the lawn for the first time this year. But we definitely see more elevations with JAKs, and we didn't really understand why. the ongoing hypothesis is that chronic inflammatory states sort of inhibit some of the protein synthesis in muscles, so kind of the idea of the wasting of chronic disease, and that whenever you reverse the inflammatory state, your myocyte metabolism sort of returns to normal, and so there's this uptick in CPK. And so it is even possible to me at this point that CPK elevations could be a marker of efficacy, of that, hey, the drug is working well in reversing your inflammatory state. I've not seen any data, like that isn't something where I'm like, if you see the CPK go up, they're gonna do it. But it wouldn't surprise me if we end up figuring that out.
That is interesting.
Yeah, there's no clinical relevance to it. So there's no, I don't check CPKs at baseline. I've never checked a CPK on a patient outside of a clinical trial.
Yeah. Do you still put patients on Valtrex?
I do. So I recommend it to everybody with AD who I'm putting on a JAK, because I've seen enough eczema herpeticum. That's what I've seen mostly in younger patients and older patients. I've seen plenty of zoster, but I've never seen either in somebody who I had on 500 a day of valacyclovir.
Okay.
Now, people will often be like, well, you should get them vaccinated, because I don't tell people to get vaccinated for shingles. And that's mainly because if I'm gonna put them on valacyclovir, they probably don't need the shingles vaccine. And even if they had the shingles vaccine, that's not gonna protect them from HSV. So it isn't like, oh, if they had the vaccine, they're fine.
Yeah, that's true.
So I do valacyclovir. Now, if they don't want to go on it prophylactically, I'm not like, oh, you got to, but I will at least give them a script for it to use episodically if they have any history of cold sores. Because I also definitely see, I've had several patients who were getting they used to get cold sores like once or twice a year. Now they're getting them every month. I have definitely seen, I've had a couple of patients like that, not a ton, but a couple.
Yeah.
And then once we put them on, those were actually clinical trial patients who I couldn't put on valacyclovir. As soon as they got out of the clinical trial, I put on the valacyclovir, they stopped getting the cold sores.
So tell me about some interesting off-label uses for JAK inhibitors.
So the most, so I was doing more research today, actually, because the problem with using JAK inhibitors off-label is that just they're so expensive and you're not going to be able to get them covered. So I was actually doing research today on Apoquel, which is the first JAK inhibitor that came out. It's for dogs. It's oclacitinib, and it's cheap. It's like $70 a month. So I was doing research of as a medical doctor, am I allowed to prescribe a veterinary medication for a human? I know I can't prescribe human medications for pets, but can I prescribe pet medications for humans? And I can't find an answer. And there's only one report of it being used in a human. It was a vet who prescribed it for himself for eczema, and he was fine. But off-label uses for JAKs. So first, the easiest answer to that is if prednisone will work, a JAK will work.
Yeah.
And in the trials, the thing that's going to be most stunning for when they come out is going to be hidradenitis. It is just incredible how well these drugs work for hidradenitis. I think the systemic JAKs are going to be great for vitiligo as well. And then literally every inflammatory or autoimmune disease that they have been studied in. So
lupus,
cutaneous lupus, dermatomyositis, pyoderma gangrenosum,
lichen sclerosis,
right? Lichen sclerosis, granulomannulare, lichen planus, oral lichen planus, CCCA, LPP, frontal fibrosing alopecia, anything. And so it's also going to be really interesting when tofacitinib, which is Xeljanz, or oral ruxolitinib, which is the oral version of Opzelura, those have got to be starting to get close to the end of their patent lives. And that'll be interesting. If we have JAKs that we can get at a very low cost it'll be really interesting to think about when we would use them in derm, because tofacitinib, we're certainly going to, if there is a JAK that has cardiovascular risk, which I personally don't think tofacitinib does either, but it's tofacitinib. And ruxolitinib is a cancer drug, and so there's a very different safety acceptability for cancer drugs. Like, cancer drugs can be horrible, but if you live a little longer, hey, blood clots are fine, whatever. So the safety data that we have around ruxolitinib it's not applicable to us. They're looking for is it killing people, not are people getting, non-fatal. It's just going to be hard to figure out how to use those drugs once they become widely available. But honestly, anything that is a rash, as long as it's not microbe related, right? So acne, pityriform folliculitis, whatever. If it is inflammatory or autoimmune, I would be stunned if a JAK didn't work. Stunned.
When you're trying to pick a JAK right now,
Yeah.
Any difference in?
Not in any meaningful way. So if I'm trying to give, what are the real meaningful differences between, let's say, Rinvoq and Cibinqo? Cibinqo is the most JAK selective drug that we have, so it is a pure JAK1 inhibitor that might have better safety implications or something, but we don't know. So Rinvoq, its main differentiator is it has the most data. And so do I think that there's potentially a risk with Cibinqo that there isn't with Rinvoq? No, but I don't know. And so it's, but we have the most safety data about Rinvoq. Cibinqo is the most JAK selective, the most selective JAK inhibitor. It really ends up coming down to, on that day, what do I have samples of? And is my biologics coordinator telling me that one is easier to get than the other? For alopecia areata, right, if I'm trying to put Olumiant in a positive light, we have dosing flexibility, we have 4 milligrams and 2 milligrams, and that's great. If I'm trying to put Litfulo in a positive light, it is, mechanistically this is different. It should work better for cell-mediated cytotoxicity, and it's only got a single dose, so it's simple. You're not going to have your patient saying, "Oh, should we do a higher dose or a lower?" There's only one dose. So, but are any of those from a purely efficacy and safety, right? If we just say efficacy, safety, tolerability, do I think that there's a reason, that I could give a solid reason, pick this one for this person? No, not at all. It's all trying to come up with, well, here's how I can differentiate those two drugs.
Yeah, that's fascinating.
Yeah, I don't think there's real, there are definitely more distinctions in the biologic space at this point. But even those, right? So distinguishing between, Cosentyx and Taltz, or distinguishing between Skyrizi or Tremfya or Ilumya. I've never been convinced that there's even a huge difference with those drugs.
Yeah.
But I'm not a psoriasis expert, so that is not me saying, oh, those drugs are not my area of expertise.
Are there any situations where you would use a JAK inhibitor first line?
Yes. So first, I offer both a JAK and a biologic first line to all of my alopecia areata patients, and I let them decide. In the situation when a patient says, I don't care, what would you do? And if they don't have any of the things I'm about to talk about, that here's when I do this or that, Dupixent is my first line just because we have the longest safety track record, we have the most data, those kinds of things.
Yeah.
I will use a JAK inhibitor. I will strongly encourage a JAK inhibitor first line for anybody who has a concomitant immunologic disease. So if you've got AA and AD, if you've got inflammatory bowel disease and AD, if you've got rheumatoid arthritis, if you've got psoriatic arthritis, any kind of inflammatory arthritis.
HS and AD.
HS. If you have anything else that's immunologic, I'm going to strongly suggest a JAK inhibitor, and especially for psoriasis and inflammatory arthritis, because we know that Dupixent is likely to make either of those worse, whereas the JAK inhibitor is likely to make either of them better. So that's the main time when I sort of push a JAK inhibitor first line, is if they have a second immunologic disease that I think the JAK's going to help with.
Okay, that makes sense. All right, I'd like to end with molluscum and atopic derm. Tell me what's new. What do I?
This is the coolest. So that's so the limited data that we have, and so this is all kind of case reports, case series. JAK inhibitors generally allow molluscum to spread. So if you've got, and I had exactly this situation. I had a 16-year-old who was doing great on a JAK inhibitor, started to get molluscum. They spread all over the place. We tried freezing them. We tried doing this, that. It kept spreading. So we took them off the JAK inhibitor and put them on Dupi. Because Dupi, the data is about 2 to 4 months after going on the Dupi, the molluscum will get inflamed, and about usually 4 to 6 months after that, the molluscum will be gone. This kid had molluscum spreading for 2 years. Finally, we stopped the JAK, put him on Dupi. His AD was actually doing better on the JAK, but his molluscum got inflamed and went away. And he is worried, doesn't want the molluscum to come back, so he wants to stay on the Dupi. So that actually is another situation where I would relatively stay away from JAKs. If I have somebody who's got, the college student who's got, sexually transmitted molluscum, or the 13-year-old who gets it for the first time, whatever, like JAKs are going to make that worse.
Okay, that's fascinating.
Yeah, and that Dupi makes them better, is it right? That it triggers the beginning of the end sign as it restores their cutaneous immunity. Yeah. So yeah, it's just cool. It's cool.
I love picking your brain.
It is like, I feel so lucky that like I got really interested in dermatitis and eczema 15 years ago, because like what we've learned in the last 3 years is so much more than we learned in the 15 years before that. Yeah. And it's only knowing how little we understood back then that makes me realize like how awesome it is that we now understand why adults get atopic dermatitis, right, for the first time, and that it's in some of the work that's being done at the NIH showing that a lot of it is driven by air pollution, which is just like crazy. Like, no, I never would have believed that. So yeah, it's just such a great time where we're getting so much better at so many of these diseases. Yeah.
All right, so if you weren't a dermatologist, what would you be?
My dream job would be a historian at a university, so in the history professor who was out talking politics, like as a talking head on TV, where I was like, well, based on the 1437 situation in Bavaria, that's very analogous to what's happening with, in Kentucky this month. And so we're likely to, that would be like hypothesizing based on obscure facts that I knew that nobody else did, so they couldn't really challenge me. That would be my dream job.
Love it.
That would be my dream job.
And if you had to get up right now and sing karaoke, what would you sing?
Oh, Devil Went Down to Georgia. I spent years learning that song. Years.
All right, maybe you'll get an opportunity soon.
It is. I'll give you let me get into, hold on a second. The devil went down to Georgia. He was looking for a soul to steal. He was in a bind because he was way behind. He was looking to make a deal. He came across this young man sawing a fiddle and playing it hot. The devil jumped up on a hickory stump and said, boy, let me tell you what. I'll stop right there.
Yeah, no,
So
that's
it's,
perfect. If
but
we had a
that's-
crowd, you'd hear the audience applause.
That's exactly right.
All right, Dr. Zirwas, thank you so much for coming to talk to us today.
This was so much fun, Hope. I had a great time, and thanks for having me on.
Yeah, thank you. Hope Cook signing off for Dermcast Live.